Hi and welcome to Chapter 12. We are talking about the upper extremity. I hope you enjoyed the anatomy review in the video above, and I want to take just a minute to begin this video by going over a few of those things. And so what we start with here first is the humerus, which is the long arm bone in the upper arm. We go down to the medial side of the elbow and we find the ulna. On the lateral side up here, the thumb side, we find the radius. Then we come down, we have 8 wrist bones called carpals. Then we look at the 5 metacarpal bones of the hand. And then we look at 14 phalanges, 2 in the thumb, 3 on each of the fingers. So as we advance into injuries at the upper extremity, and we are going to be talking only about the upper extremity, we're going to save the shoulder for the next module. But as we go forward with this, we want to concentrate on the most common acute mechanism. And the most common acute mechanism is this word right here, FOOSH. And that is an acronym that stands for fall on outstretched hand. This is a very important thing for you to understand because most of the things we see with the upper extremity happen because someone fell and they put their arm out like this, and when they landed, they accept all of their body weight on top of this upper extremity, and typically they'll have some energy behind that. So, with that being said, let's talk about the big acute injuries that occur with these bones, joints, and muscles. So, starting out, we look right here. The humerus. Where we see humeral fractures is typically right here in the middle or the mid-shaft area. A lot of times we see them and they are spiral fractures. Sometimes they're transverse, which means they're flat and straight across, but most of the time they're spiral. And what happens is when that athlete fooshes or falls on an outstretched hand, they have that energy coming behind them and their arm becomes fixed into the ground or the surface that they're on, and we have that energy coming behind them, and that causes a rotation around this bone. Many times that shoulder will dislocate, and hopefully that's what does happen. When the unfortunate circumstance that the shoulder doesn't dislocate, they will have a spiral fracture, and that literally is a twisting of this shaft and causing a fracture to occur. Very painful and typically requires surgery to put it back together. Next one on our list is the ulna. Now the ulna, the medial bone of the arm, is fairly safe and protected from fracture, except for from blunt force trauma. So what I'm thinking here is an apparatus in a sport like a puck, a hockey stick, a baseball bat, a football helmet going right onto that, different types of sports equipment that may come in contact with that ulna, kind of from a guarded position, may fracture the ulna. It's awful rare that you see someone fall on an ulna with a flexed arm and break it, but it can happen, and it can also happen with an outstretched arm. They can still break the ulna. Most of the time when they outstretch their arm and they break a bone in the lower arm, what they break is the radius, and they break this very end of the radius right here. And usually what happens, and you'll notice I am holding this arm out, this is the palmar side, and I'm rotating it over here. And typically what will happen is this radial head will displace posteriorly or dorsally. And when that happens, they get a Colles fracture right here. And that's the most common fracture in the forearm. Second to it is a Smith's fracture. It's the same fracture, distal head of the radius. However, it displaces anteriorly going forward, or volarly or palmarly, however you want to say it. Next on our list is the carpal bones. The most common fracture in the carpals or wrist is this bone right here called the scaphoid. And it's very difficult to see probably in the video here, so I'm going to ask you to go back and look in your textbook to find this. But this bone right here is very susceptible to fracture from a FOOSH injury, especially because that wrist extends and it compresses that poor little bone in between the other carpals and that radial head, and it receives a fracture. Now, this is probably the one that I need to give the most attention to. A lot of times we think when we fall on an outstretched hand and we have wrist pain that it's a wrist sprain, and many times it is, but many times it's not, and it does have a fracture in there. And these fractures to this bone are very difficult to pick up. A good example of this is a athlete that I had here at Carl Albert State College. Fell on an outstretched hand, had typical symptoms of a scaphoid fracture. We sent him for an x-ray the day of injury, and he came back and he said no fracture. Had pain for weeks and weeks and weeks after the incident. We sent him back and they said, yeah, he did have a fracture. And so what we learn about that is that fractures in the scaphoid sometimes don't present in the first few days. So I would even give it 10 to 21 days. If it's still painful in that wrist after a Fuchs incident, I would go ahead and send them in for a reeval or repeat of those radiographs. Now, what you can do clinically is you can look at this bone and say, how do I examine this to know if this is even potentially fractured? Well, what I want you to do is I want you to take your thumb and I want you to pull it out as far as you can, spreading your hand out. And what you'll notice are these two tendons right here. And this is your abductor pollicus longus and your extensor pollicus longus. And those two tendons make up an area called the anatomical snuff box. And you can see this little divot right here in my wrist. And if you'll take your other thumb and you'll push it on into that little anatomical snuff box, you'll find that it's pretty tender. If the scaphoid is fractured, that's going to be really tender because that's a direct palpation area for the scaphoid. Another thing you can do is you can take that elbow, bend it, show me your handshake position, put that athlete's hand in yours, and you can radial deviate the wrist. And what happens is you compress that scaphoid bone against the styloid process of the radius. And if it is fractured, that's going to cause pain as well. So if you have two tests that cause pain, you have a Fuchs injury, go ahead and get that x-ray. But keep in mind, you may need to send them back 2 to 3 weeks later, especially if they're still having pain, to rule out a fracture. Next on our list are metacarpals. Metacarpals become fractured, and remember, that's the bones of the hand right here. And they become fractured from Fuchs, but the one that I want to point out, as I have written here behind me, is the boxer's fracture. Now, that's you taking your hand and you punch something, and what happens is this metacarpal right here, the fifth metacarpal, has some pliability to it, and you can kind of wiggle your own right there, and you can see how I'm moving mine. Well, at the end of that, pliability becomes a stopping point in the infield, and therefore the physics from a punch, which most commonly from an untrained fighter, happens to be landing right there in that into that fifth metacarpal, transmits down to mid-shaft. That axial load then occurs and fractures right there. A lot of times that's a surgical procedure as well. They have to go in and put a little pin in there and a plate. Now, again, that is not something that you expect to see a lot of times out of sports, but as you can imagine, we see some people get upset and they punch things like brick walls, which has nothing to do with sports, but something you still may see. Next on my list are the phalanges, and any one of these little things right here can have a fracture. Now, remember I said you have 2 phalanges in the thumb right here and 3 in the fingers. And so if you look at it, you can have any one of those bones get fractured, but typically collision and contact sports are where you're going to see that. I have seen that before in sports like basketball, where someone just reaches out to try to catch a basketball and it hits the end, causes an axial load, fractures a finger, and just like that, a person has a broken bone. Now, going to the other side of the graph here, what we see are some very common sprain areas. And remember, a sprain is a ligament injury. What I want to start with right here is at the elbow, and that is where the humerus and the ulna come together. And on the medial side, you have something called the ulnar collateral ligament. This is very commonly spoke of in baseball, and we see baseball pitchers who are throwing the ball repetitively develop an overuse injury of that ligament. Still a sprain, but an overuse type injury, and they get a lot of laxity, and so it's very hard clinically to assess that. But you can do a little valgus stress on that ligament to see if it's loose, but in a pitcher it probably is loose. And so an MRI scan is the standard of which we measure true injury to the ulnar collateral ligament. The repair for that is a Tommy John's surgery, and there's a lot more coming on that, and I hope that you'll do some research on your own to see what Tommy John surgery is and how it occurs and why it occurs. But that's kind of the common fix for that ligament when it is injured, specifically for baseball players or overhead throwing athletes. Next on my list is right down here at the carpal bones, and that's a scapholunate sprain. And so I bend the elbow, I have the top of the wrist exposed to me, so here's the radius and here's the back of the wrist. And what I'll do is I'll actually grab a hold of that scaphoid and that lunate, and I'll kind of move them around. And if that's where it's painful, that's good, because that means it's probably a sprain. But again, go through your precautions and make sure that scaphoid is not at risk of a fracture. And then our last big sprain that we see is right here at the thumb, and I'm actually going to show you on my thumb here. And what I want you to do is I want you to notice how on your thumb you can notice a little ligament right here that goes from the carpo-metacarpal area and to the carpo or to the metacarpal phalangeal area, and that ligament is also known as an ulnar collateral ligament. I'm not real sure as to why they decided to do that, other than it's on the medial side, but they gave it that same name. And what happens is the thumb is abducted forcefully from the hand, and it sprains this ligament. They call it gamekeeper's thumb because in olden days, when people hunted with dogs, specifically rabbits, they would grab the rabbit, and there would be one person dedicated to taking care of finishing the rabbit or terminating the rabbit after it had been caught by a dog, and that would be by twisting its head. And so as they did that all day long with many rabbits, they would develop a little sprain there. So that's why they call it gamekeeper's thumb. Now, one last thing that I want to talk about here are dislocations. From a Fuchs injury, we typically don't see a lot of dislocations at the shoulder, but we do see some from the elbow and also down in the wrist and into the hand and fingers. Most commonly, though, right here at the humerus and the ulna is where we're going to see a elbow dislocation occur, and typically that happens where the ulna displaces posterior to the humerus. If that happens and you can pick it up pretty fast, it's a big deformity. That is a very limb-threatening injury, and you need to give it quick attention with an ambulance, activating EMS. However, if a person dislocates a finger, that's not usually something that's limb-threatening. And many times I've put fingers back in. I don't recommend you do that, but I've done it under the supervision of a physician where they have a finger, and typically it pops out, and what it does is it will come out from the distal end and it will lay on top of the proximal joint like this right here. And so it's pretty simple to put them back together, but a lot of times athletes don't want you to do that because it's very painful. And so to put a little medicine in there to relax them typically helps that. So again, my recommendation, don't try to reduce any dislocation that you find. Always splint it the way you found it and refer them for emergency medical care. That is our fractures, our sprains, and our dislocations for our upper extremity. What I want to do now is I want to direct you to the next video down, which is going to talk all about soft tissue injury of the upper extremity. If you have any questions, don't forget to email me. Have a good day.